episode of Ultrasound Podcast, where we dive deep into the cutting-edge practices and game-changing innovations in medicine today. If you are passionate about emergency medicine and have a keen interest in the incredible power of ultrasound technology, then you are in for a real treat. Today, we have an extraordinary guest joining us. He is none other than Dr. Conor Kelly. Conor is a specialist in emergency medicine and the clinical lead in ultrasound at one of the busiest hospitals in Australia. Conor has been at the forefront of integrating advanced ultrasound techniques right into the heart of emergency medicine. But that's not all. Conor is also a dynamic educator. Conor has trained a lot of doctors, nurses, medical students, and paramedics the ultrasound guided vascular access techniques. So without further delay, please join me in welcoming Dr. Conor Kelly, the clinical lead in ultrasound and a true visionary in emergency medicine. Hi, Conor. Thanks for joining us.
Excellent.
This is a
Thanks
very
for having
interesting
me.
topic.
I appreciate being here. Privileged to come to talk to you.
Yeah, so the vascular access under ultrasound guidance, I found it that this is probably the most common application of ultrasound in the emergency department that I do. I cannot remember how many times the junior doctors or nurses came to me and say that we could not get the access. Can you help us? And the ultrasound came to my rescue in getting the IV access. So it's not only the venous access, but also the central line, arterial line, the vascath line. It helps me a lot. So I thought that we'll talk about it, and I will get some insight from you and some expert opinion from you. So first of all, Conor, tell us a little bit more about the evolution of the ultrasound in the access of the vessels, the veins and arteries in your practice. How did you find it so far?
Yeah, so obviously ultrasound's been around for quite some time, probably like in documentation of probably 20, 30 years. But in terms of use for purely venous or vascular access, I think it's really only crept into practice maybe in the last kind of 10 to 15 years. And I think we're kind of moving from that traditional old school approach of using as your last resort for those more challenging patients to maybe using it up front, first line, making your first go the best go. I think in my clinical practice, I find I'm probably have a lower threshold to do that up front rather than, you know, trying and failing or getting junior staff to fail multiple times. So I think it's probably becoming an everyday occurrence rather than a once in a, you know, rare or blue moon occurrence. Does that make sense?
Yeah, absolutely. I think that is my experience as well. So sometimes if from the look at the patient, for example, an obese patient or a lot of scars or previous history of difficult IV access, I would use ultrasound straight away. I would not use the traditional landmark technique and cause more tissue injury. I think that is what I do these days as well.
I agree. I think there's been a shift, like a cultural mindset shift, like departmentally, but it does vary obviously depending on your access and resources. I think depending on the department, but yes, I think we're using it more and more these days than not.
Yes, exactly. And with regards to the vascular access techniques, I'm going to show some animations and some examples as well. Please tell us about what your perspective is. So the main technique that I use, Conor, is offline technique. How often do you use offline technique and inline technique?
Yeah, that's personal approach, isn't it? It's so in plane or out of plane technique depending on the ergonomics. So I actually prefer the out of plane technique, like you said. So you're looking perpendicular to the longitudinal aspect of the vein or artery, depending on your target. And then with your trocar needle cannula, you're going to always fanning, as I can see from this diagrammatic illustration, but finding your tip, and then as you fan the linear probe forward, you're going to find your tip and advance forward. So usually once you get expert and mastery at this, you can actually follow the tip all the way in a smooth transition to get it into the middle, to puncture the vein, the proximal or the anterior wall, and then into the intravascular space itself, and then advance in a smooth motion. Obviously, this is compared to an an in-plane technique, which you're going with a probe axis linear or longitudinal to the venous axis. Sometimes that could be useful, particularly more in arterial axis, where you've got a larger target, etc. But I prefer myself personally using that out of the plane technique. Once you master that and understanding the physics around it, particularly in relation to that ovoid shape, circular shape, and then never lose the tip, is quite the pun, but I think that's the key aspect with that.
Exactly. And in this animation, I'm trying to show the same thing. So this is a needle or a cannula, and this is the ultrasound probe. Obviously, this is a linear probe. And the most important thing, as you have just said, I always look at the tip, and I will follow the tip. And if I gradually push the cannula slowly towards the vein, as you can see on the screen here on the right-hand side, the tip of the cannula is just piercing the superficial wall or the anterior wall of the vessel, which may be an artery or vein, depending on whether we're doing the venous access or arterial access. And as we are going through deeper and deeper, I am sliding the probe distally towards that, and always the tip of the needle is in view. Sometimes I find it a little difficult to find the cannula or the needle. And in that case, I do a little bit of rocking movement like this. A little bit of rocking movement will make the surface of the probe parallel to the needle. How do you find about this, Conor?
Yeah, I think that's key. What you hit on the kind of nail on the head, so to speak. Those subtle probe movements to optimize your image and find your tip, and then slow adjustments is key. I think you could do this quite fast and either inadvertently go past or through the vein without even realizing it. So I think slow, subtle movements till you get masterful in terms of the level of that hand-eye coordination, but also double hand techniques of using both the probe to fan and heel tollage, and then also with your dominant hand, ideally with the trocar. And I think slowly but surely is key. I think just to find that tip, lose it again, find it till you get that advancement. It takes a bit of time to master that. It's a new, like anything, it's a skill. You just need to practice.
Exactly. And it takes a lot of practice to actually be confident and do it independently. And as Conor has said, that always keep an eye on the tip of the needle, and the tip of the needle will look on the screen just in the center of the vessel, and that's very important. Now, this is one of my examples. I show it to my colleagues. So this is the vein, and we can confirm this is a vein because it is completely collapsible on pressure. And once we identify that this is a vein and we are going to do a peripheral venous access, then we are going to introduce the cannula, and we can see that the tip of the cannula is just on the superficial surface of the vein, just about to puncture. And as we push it a little further, the tip of the cannula has just gone to the center of the vein. And we can confirm now from the ultrasound that we are actually successful. And this is another example, the similar thing, that we have got a vein which was not possible by the traditional method, so use the ultrasound. We are confirming that this is the vein, not the artery, because it is not pulsatile and it is completely compressible. And then we are making it a little bit, we decrease the depth and have a look. And then we are introducing the cannula. And here we go, there's the cannula coming from the superficial to the deep aspect. And now I'm confirming that the cannula is just in the center. Do you have any specific technique to make sure that the cannula is exactly going through the center of the vein, not on the side, Conor?
Yeah, so my approach in terms of the nuts and bolts of technique is to line everything up. So using ultrasound, the ergonomics around it's very important. So there's a good video from actually Adam O'Brien. He's one of the famous PEM consultants at RCH, and Jeremy Friend, who also works in Geelong. They have a video that's on Vimeo, but you want to have that, the holy trinity of the ultrasound, the patient or patient's arm, and the practitioner, doctor, i.e. lined up in one line. So when you're advancing your trocar, your needle, ideally if you can do it in line. If you're coming in sideways, there is a risk with that you could inadvertently have gone past it or to the side of the vein itself. But I think approaching exactly in the middle, aiming for the tip to hit the top or superior part, the middle off the vein, because you have the biggest depth. So if it's you sometimes can see it on an angle and it's quite ovoid, and it gives you a false picture that it's actually longer than what it is. Because if you hit it directly at 90 degrees, it could be a smaller target. So it gives you there is considerations to think about with ultrasound. Depending if your probe is angled, you're going to get this ovoid shape. So being mindful, if you're hitting it directly dead on 90 degrees, you're most likely to have more success. If you were to hit it slightly angled, there's actually a shorter distance you have to play with. Does that make sense in terms of margin of safety?
Absolutely, yes. I completely agree with you what you have said. That's ideal, and that's we try to do all the time. The reason I am showing it, that many of the times we find that the vein is quite deep or the vein is not quite straight, it's tortuous. So the point where we are hitting, it is not quite ideal. It is not hitting just in the center, it is hitting on the side. And
exactly. And
I completely agree with you that ideally it should be in the center.
I agree. I think sometimes patients with maybe more adipose tissue or those rolling veins, and sometimes it is hard to get that purchase, and they do move, or they're moving in the middle of procedure, and you find your tip maybe somewhere else, and you have to readjust during the middle of the procedure. And that's obviously that these things happen. You can't always predict or, mitigate that.
Exactly. So in case of, if the things don't go according to the ideal scenario, for example, this one, that where the cannula is, or the tip of the needle was not in the center, it was not hitting here, it is hitting on the side. Do you use any other techniques to help the success or increase the success rate?
Yeah, so there's a lot of troubleshooting you can do with this. The advantage of ultrasound obviously gives you a better visualization of what the problem could be if you have that insight. So I think, firstly, if you haven't hit the vein at all, that's fine. No harm, no foul. It could be in the subcutaneous tissue either side of it, or just still superior to it. If you have inadvertently gone through the vein or sliced the wall, the tip might be in the underside or underneath to the posterior wall, you could have some extravasation there, but it can still be salvageable. So by slowly pulling the trocar back, looking for that tip, find that tip, ensuring that you're in the middle, ideally the middle of the vein, so intervascular space, and then slowly deploying your cannula, the plastic cannula, you'll be still able to salvage it. So depending, and if obviously you're completely off plane or offline to the side, then you may need to pull out, not all together, but a little bit, just to reset or reorientate yourself, and then proceed accordingly again.
Thank you for sharing that tip. And in terms of the inline technique or in-plane technique, that's a very interesting topic. And theoretically, I think that's the best technique. But the problem I find is, as I've said, that the vein is not quite straight line. And it's not even in completely parallel to the skin. Sometimes it goes deeper and superficial. I find it really difficult in case of peripheral venous access to use this technique. However, in case of the central line, I think this is a very good technique. How do you find about the inline technique, Conor?
I agree. I think for peripheral access, it is difficult because you have a smaller target, and it really requires very fine motions to line up the whole barrel of the trocar with the venous or arterial access.
Mhm.
In terms of central access, because you've got such a larger target, I use it in both planes to confirm like a larger, say, such as jugular, IJV placement, and then confirm wire placement thereafter to make sure you're in the right place before you deploy the quad lumen or central line.
Mm.
And I think the skill, it is still a good skill. We use it a lot, say, you know, in regional anesthesia, inline technique.
Mm.
So you want to see your sono needle, the needle going the whole way in. I think it is a skill in itself, mapping that needle the whole way so you can see the tract and where you're going to get that neurovascular spread of injected. But I think if, for example, you can't obtain your needle, or it could be difficult visualization depending on the probe, the resolution, it is another backup technique. It wouldn't be my first line, but I think just to see where you are in space with the needle, and then go back, so you can alternate between an out-of-plane approach and inline approach to confirm where you are in that 3D space, because with ultrasound it is a 2D model, and I think, you know, we get used to looking at that, but there is that 3D aspect to it, I think. So sometimes that troubleshooting, if you're a smooth practitioner and been able to adjust pretty rapidly with your probe, then it's a great backup technique.
Thank you. So that is exactly what I do, and a little bit of background story for those who are not familiar with this. So this is the same ultrasound probe, but this time we are rotating 90 degrees so that the probe length of the probe is parallel to the vessel, the vein or artery, for example, and parallel to the needle or the cannula as well. And just like the off-plane or offline technique, we are using the same very gentle introduction of the cannula and gentle sliding of the probe. And as we do this, always we keep an eye on the tip of the needle. And as we can see here on the screen, that the tip of the needle is just going into the vein, but still not quite in the center. So we are pushing it a little bit further and a little bit further. And we are still keeping an eye on the tip of the needle. And we have got beautiful reverberation artifact on the screen, because the ultrasound that goes in straight line and it is going to and fro, and that is giving a little bit of reverberation artifact there. How do you find about this, Conor? Any suggestions about this?
Yeah, I think in terms of inline technique, it does have advantages and disadvantages. Seeing the whole length or the needle approach, and you can tell really accurately where the tip is and where you're going to deploy your cannula. I found that really helpful for, say, a long cannula. If you're in a patient who's very challenging and you're going to put in a longer cannula gauge, then you can actually see the whole deployment and how long you're in and where exactly you're going to avoid inadvertent extravasation. So there is, like you said, the artifactual aspects of that. In terms of needle, you can get this reverberation line underneath. You need to be mindful of that. You're not getting, there could be error associated with that. But I agree. I think it has its advantages.
And this is a good example that I confirm that this cannula is in vein, inside the vein. So this is the vein, this is the superficial wall, and this is the deeper wall. And this is the cannula, which I can see beautifully, that whole length of the cannula I can see. I can see the entry point here, and I see the tip as well. And I am confirming that the tip is still inside the vein. It has happened so many times when the colleagues came and they said, oh, we have put a cannula, but I cannot draw any blood. And I did the ultrasound and I found that the tip is not sitting here, the tip is sitting here. So it has gone through and through. And this is another example. Again, this is a beautiful vein there. Because there is a tourniquet proximally, the blood is not flowing, so it is stagnant. And I can see that the entry point of the cannula is here, and the tip of the cannula is still inside the vessel. Sometimes there may be a little valve that obstructs the tip. And so when you aspirate, there may not be any blood. So Conor, do you like to add anything about this this inline plane or in plane cannulation?
Yeah, I think it's a great way to confirm post that you're in the right space. So obviously, maybe using an out of plane technique initially to line it up to insert, and then you can use it midway or at the end to troubleshoot and check, confirm you're in the right space. And as you said, there are a lot of errors with that. Sometimes they can be an intramural placement or a posterior wall or extravasation without even realizing it. It can be so subtle. So I think it probably has its uses in terms of confirmation. In terms of using an inline technique to insert, it can be probably more technically challenging than an out of plane technique, I find, until you reach that kind of expert level.
Yeah, absolutely. I completely agree with that. So the only time the inline or in-plane technique may be useful in case of a large vessel like an internal jugular vein or a femoral vein, but otherwise it's very challenging. The best thing to do is to do the cannulation in the offline or off-plane technique, and then confirm it by this inline technique. So I've got another recent case that I have done just to illustrate the ideal scenario. So this was a patient I have seen just last week, actually. It was a 45-year-old lady. She attended the emergency department with abdominal pain. She's quite obese. She's 120 kg. And the nursing staff and intern, they failed a few times. So they asked me to get an access. They were telling me before going to the patient that this patient has got very difficult vein. I did the ultrasound, and as you can see that in the ultrasound, she's got beautiful veins, no doubt about that. The vein is beautiful. The problem is there is a lot of subcutaneous tissue. And in the usual technique, which is the landmark technique, it was very difficult to actually fill that vein. So they were trying to do the cannulation on the side, but the cannula was not going through the vein because it was very deep. And this is the commonest problem with the so-called difficult venous access. They have got beautiful veins, but the problem is they are quite deep. And I'm confirming that this is a vein, not the artery, because on pressure, it's completely getting flat. So this is not an artery, and this is not pulsatile. And next, I have identified this is just in the center of the screen. And as we can see that this is the tip of the cannula that is just touching through the superficial wall of the vein. And as I am pressing a little bit further, I can see that the tip is just in the center of the vein. And I'm pushing a little bit further, making sure that the tip is not touching the deeper surface of the vein. And once I'm confirming that, I'm taking the trocar out, and I can see that the cannula is there, the plastic part, which is quite circular here. And that is just on the surface of the posterior or deeper wall of the vein, but it is not going through and through. And now, as Conor has said, I'm confirming with the inline or in-plane technique that the cannula is in the vein and the tip is still in the vein. It is not going through and through. And now I am 100% confirmed that I have got a successful cannulation. Now I can take that blood, I can give the medications, and that's a successful cannulation.
Beautiful. That's a really good example. And even on your AP or the kind of initial picture, the advantage there of ultrasound, because there's actually looked like there's a hyperechoic structure underneath that vein, like looked like potentially like a neurovascular bundle or a nerve as well. So that inadvertently would prevent against nerve injuries. That's another advantage, given that it's a little bit deeper. I think that's a really good example.
Yeah, exactly. So that otherwise in blind technique or the traditional technique, that particular structure probably is the nerve that may be injured.
That's a nice video. Beautiful.
Yeah, thanks. All right. Now, in your practice, I'm pretty sure you came through lots of different guidelines and a lot of different policies about it, Conor. Tell us a little bit more about these ultrasound guided vascular access guidelines that affects your practice.
Yeah, so obviously as an emergency physician in a busy kind of tertiary department, there are a lot of, we've local policy, then there's kind of the state or national guidelines with in relation to ASIM. I feel like having looked at this over the last few days, the ASIM guidelines in terms of access, not really mandated. It's not that, they haven't probably caught up to what we're doing in current practice in terms of ultrasound guided access. Within our department, there is kind of either local precedents or, and it's not policy actually, in relation to who can and who cannot insert access under ultrasound guidance. I've actually looked into this. I was trying to start a local program in getting our senior nursing staff to insert a cannula under ultrasound guidance. And there is precedence for this. Other places, other large hospitals such as, you know, Gold Coast, off the top of my head, and Alfred Hospital, I think, have their nursing staff that have been upskilled to do this. So there's senior staff, and that's again taking off some of that workload off the medical staff, because invariably, you know, as you said, mentioned earlier on, you know, there'll be multiple people, clinicians, the medical student, the junior nurse, intern, HMO, or junior medical officer, whoever, that will attempt this before they then turn to the physician or consultant, and that patient has been treated like a pincushion for, you know, multiple patients from multiple clinicians. I think we should look at developing some kind of standardization around that in terms of who can and cannot like insert this. I think it's not beyond the remit or scope of practice of either junior medical staff or nursing staff, to be honest. It's an extension of what they already do in terms of performing peripheral IV cannulation. It's just around the standardization and the policies around the governance. I think at this point in time, there is no kind of national policy that it's just more of a standard of care, that if incompetency in relation to ultrasound, but it's not tested. It's not what we do test is the outcomes or complications of that. So either, you know, inadvertent risks such as thrombophlebitis, clots, etc. They're the ones that are maybe targeted, and then we look back at who's performed that cannula. But I think the guidelines probably have a lot further to go. It's that double-edged sword. You want to obviously be safe, you want governance around that, but you don't want the police or the Nazi police and saying who cannot do this. I think there's actually a lot more scope of practice we can improve in empowering our nursing staff and other clinicians to do this as well. I don't think it's limited to only the physician.
Yeah, absolutely. So with regards to the ultrasound guided vascular access, I mean, probably this will be one of, as we've said, it's a standard of care. This is a very basic skills. And without the IV access, that particular patient care may be affected. So it does not matter whether it is done by the nurses or a doctor, as long as they are trained, as long as they are confident, as long as they know what are the pitfalls and what are the limitations. And if it can help the patient, obviously this is very useful. And I think you are doing a fantastic job in your hospital, training the senior nurses. In my hospital, I'm also trying to get this organized, and we'll get to that in a minute. Now, with regards to the guideline itself, as there are quite a few articles I came through. I gave it to you. I believe I gave you a link to you. This is an article, little old, from 2012, which is a recommendation based on the articles which are published in the 10 years before this article. And they recommended a few very interesting things. And if somebody is interested, they can go through this article. As I've said, it's a bit old. It's a 12-year-old article, so things have changed a lot over the last 12 years. But still, they have made us very important, very interesting recommendations. What type of probe we will use? What will be the setting of the probe? For example, we'll use a high resolution or low resolution, this sort of things. The one example for this type of practice is if the vein is superficial or artery is superficial, use the high resolution probe, because high resolution probe has got better resolution but limited depth of penetration. So it will give you a beautiful picture, but it will not allow you to see deeper structures. That's fine. So there are a lot of these recommendations from this particular article. So I found it very useful. If somebody is interested, I'll leave the reference later. The other article, as you have said, that from the Australian College for Emergency Medicine, there is no specific guideline for the ultrasound guided vascular access. However, as you are aware that from last year, ultrasound is now mandatory for the trainees of this college. And one of the mandatory skill set is the ultrasound guided procedures, and that will include vascular access as well. There are quite a few modules available in the college website, which can be accessed by the trainees, the physicians, as well as non-college members. They can also access. If they request the college, they will give you the access free of cost, of course. And there are a lot of videos and a lot of materials there where the different techniques about getting the vascular access can be obtained. With regards to the guideline, the college itself doesn't have any obvious guideline. It just says that the college supports the use of ultrasound for the ultrasound guided procedures, for example, vascular access. With regards to the ASUM, again, there are some guidelines regarding the venous ultrasound, but not about the vascular access. So that's about the guidelines. Now, with regards to the specific applications, I think we have already talked about it, that we can use the ultrasound for peripheral access, the arterial line, the central venous access, vascat, etc. Do you have any other specific application in your mind, Conor?
Yeah, I think there's like it's endless. The sky's the limit, really. I think, on that note, it's very hard to make it mandatory because it depends on people's, expertise, their competency in craft group. Like if you had a senior anesthetist with years under the belt, they could get a 14 gauge in somebody without even looking, as opposed to the medical student in the same patient mightn't be able to get a 24 gauge. So I think there's a line there, a learning point. I think everyone needs to check themselves in terms of their own competency and skill set. So if they think they're unable to get it, maybe they should reach for the ultrasound earlier and at least to have a target, to have an aim, rather than this blind, landmark or palpation technique, which does have a higher rate of failure, but it depends on it's very operator dependent. Like ultrasound in general, cannulation is operator dependent. So I think it's very hard to police that, because there is that old school traditional method of people want to try and fail versus the newer generation where I think they want to make their first go the best go. So it depends, but I feel like the applications are endless in relation to ultrasound use. And every time, like particularly for myself in regards to, like, say, central line, 100% of the time. Arterial line, I actually use it all the time now because I've got big fingers. So my use of the palpation technique for finding and palpating a peripheral pulse, I always use it to just, it always improves. Like I get 100% success. I feel there's definitely that standard that he said in terms of nearly risk of negligence if you don't use it, particularly in relation to central line. I haven't seen that someone insert a blind or landmark technique in years. I think that as a risks, I think it's a 30% complication rate in relation to blind central line insertion. Yeah. So now I feel like with the current rates are here in Geelong, I think our current rates, the infection rate is like less than point something percent, less than 1% or something. It's negligible. Yeah.
Excellent. Thank you. Now, obviously, like any other medical procedure, even if it is ultrasound guidance, the vascular access can have some challenges and some limitations. Tell us a little bit more from your personal experience, or what have you understood about these challenges, and most importantly, how we can mitigate them, how we can address those challenges, Conor?
Yeah, I think there's multitude of challenges. It depends on the circumstance, but as I mentioned earlier on, it depends firstly the practitioner, their experience. I think depending on the department itself, where you're in, where the patient is location-wise, the busyness of the department, where the machine is based, how far away from the machine, how many machines you have. Sometimes it is the decision just to use it, but just with the system issues that go around that, sometimes, if you mightn't have time to do it, if depending on competing priorities in a busy system, and we're all busy these days. But it's that counterintuitive aspect that the use of ultrasound will actually make your first, attempt your best technique and increase your chance of success. So it actually saves you time, counterintuitively.
Absolutely. Yeah.
But there are obviously limitations around. I think with the use of ultrasound, having that governance, I think we should have more governance and policies, and developing a local policy around that, and education, and for both medical and nursing staff. So I think that should be enforced. And then there's a whole other thing on cleanliness, probe cleanliness. I know they wanted to talk about that now, in terms of, particularly because it's a bodily fluid, the risk of, bloodborne infections, needle stick injuries, and then also the probe itself harbors, bugs if not using proper.
So Conor, tell us a little bit more about the challenges and limitations that you face, or you are aware of, about the use of ultrasound for vascular access.
So yeah, we touched on some of the systemic issues. So obviously departmental factors, having use of ultrasound, location, the number of ultrasounds you have, if they're busy or not. We talk about sterility, use of bag, bands, having enough cleaning material, so proper UV wipes who don't damage the plastics. And we also have a UV machine that actually can sterilize for microbes post that, and there's labeling around that, and governance around that. And our CLU or co-CLU within the department, or clinical lead in ultrasound, we kind of try and keep an eye on that weekly, and looking at the machines and uptake with biomed. So that's to do with the probe. Obviously then there's the individual factors, like who essentially is performing these procedures. It tends to be in our hospital mainly medical, so either senior registrar or physician or consultant led. But I think even now there's some precedents coming in junior medical staff, and from a university led, they're actually starting that earlier and earlier. So it's actually been introduced a lot earlier in their curriculum and professional lives, which I think actually has an advantage. That then it's not, because it's eating into that senior clinician time. If you have to, it's rate limiting if you're quite busy and you have to step away from some other, other challenges, on the floor where you've got multiple priorities on the go. So I think that will be advantageous. The other limitations in terms of this we touched on with training other non-medical staff, so nursing staff, and empowering them to perform this procedure in terms of under their scope of practice. But there are a few limitations with that. So they require a lot more. I feel like for medical staff, sometimes, they might see one, do one under supervision, and then they're good to go. Nursing policy, I think, is different, where they require a lot more credentialing around that, a lot more supervision as part of their scope of practice to feel like they can do that safely. So I think both of those parallel processes need to happen together. But I think with some standardization, policy change, education, I feel like that is possible for the future. And I think ultimately we need to look at our own. We've changed the policy in terms of the documentation in terms of cannulation. We've had an increase in bacteremia or bloodborne infections. We've noted within our hospital. And there was no documentation of who or when that cannula was placed. It could have been paramedic placed, or in ED and not less than ideal condition. So we've improved our documentation around that to try and really target or decrease the risk of cannula associated infections, and particularly ultrasound guided cannula associated infections. Does that make sense.
So when you say this particular increased bacteremia, was it under ultrasound guidance or was it non-ultrasound guided?
So I think a majority of these were non-ultrasound guidance. So I think the use of ultrasound and taking the time in terms of sterility will actually improve that and decrease the risk of infection. I think ultrasound actually will improve it if using the proper technique, including the plastic sleeve or bag, sterile gel, and a contact medium, and education on that. I think that could substantially decrease the risk of a bacteria or skin-borne infection. Because if you're having multiple attempts as well, that patient is higher risk of morbidity. Because I think these procedures, I think we think of them as low risk or zero risk, but compared to say, everyone thinks of a halo or high acuity, low occurrence procedure like surgical airway or thoracotomy, etc. But on that curve, that acuity frequency curve, these are, high frequency, high occurrence. We do it multiple times a day, like you said, but it's not zero risk. It's actually higher morbidity than you think, including, high risk of thrombosis and multiple thrombosis. You have multiple attempts, phlebitis, local phlebitis, and I've seen even cellulitis associated with it. Foreign bodies, I've seen, unfortunately, some of the needles break. And that's just a physical commitment. And then obviously that requires further attempts by a senior clinician, and they have to go for deeper structures and the higher risk of hematoma and DVT even, I've seen, as a complication. And then there's a psychological impact on the patient themselves, becoming quite hospital adverse, needle phobic, and even I've seen people with PTSD in regards to, traumatic hospital experiences in the past in relation to particularly cannulation.
And you're talking about, I'm sorry, Conor, you are talking about ultrasound guided cannulation, or?
Well, I think ultrasound guidance will actually improve that, but I think it's just that these events, cannulation in general, is not zero risk.
Yes.
I think so. I think ultrasound can really mitigate or ameliorate a lot of those complications, and some of them are unseen or maybe less documented than we think. Does that make sense?
Yeah, absolutely. Yes, I completely agree with what you said. So ultrasound itself has got multiple complications, and I think from my personal experience and what I have seen so far, it actually can decrease those risks significantly. And that brings up to the next important topic that you are talking about: training and skill acquisition. Tell us a little bit more about the training that you are doing in your practice for the junior staff, like the interns or medical students or the nursing staff that you mentioned earlier.
Yeah, so locally we have a few things happening. Like we have our in-house registrar, both unaccredited and accredited ASIM trainees, that we have multiple procedural skill days throughout the year, and one of those skills is ultrasound guided cannulation. We have some of those blue phantom models, so you can get actually like plasticine or kind of like rubber feel like within kind of fake veins within it that are quite that good. Even just getting down the technique of using ultrasound needle technique approach, it doesn't have the same real feel, but I think it's a good surrogate. And then I've seen some other hospitals employ the use of animal model, which can be controversial, but like chicken or whatever with plastic around, or cling film, cling wrap, which gives a bit more realistic feel. It's obviously a much cheaper alternative compared to buying the blue phantoms. I should say there's no conflict of interest with the blue phantoms. No financial gain. So that's one that's getting the nitty-gritty techniques around that, and then with the nursing model, we're trying to bring it in service, and we're just currently speaking with the clinical nurse educators and hopefully trying to get something going soon in empowering our nursing staff and improving their scope of practice. And even within the junior medical staff group within the hospital, there have been they've lunchtime teaching, and I think the anaesthetist had recently been doing a workshop on them with them in terms of ultrasound guided cannulation for all junior medical staff groups. So I think the value, because they've realized the value as well, not just the ED physician, anesthetics, because they're usually the backup for the hospital inexperienced cannulators, so they usually called multiple times for junior medical staff to rescue them when they're in strife. So I think they've taken the bull by the horns as well, and also realize the value of education and training junior staff, so then they're called upon less and less. Does that make sense?
Absolutely, yes. I think that's you are doing a fantastic job there. There are multi-level training program, multiple different techniques are used. So how do you maintain that training? Do you use any logbook for example, if the ASM trainee, that person is getting the ultrasound guided vascular access module tick box done, and then do you use any logbook, or how do you actually maintain that training?
So that's true. I think obviously for the ASM trainees, there's that non-mandatory modules like the core modules, the big five, like the cardiac, lung, EFAST, gallbladder, AAA, etc. IV cannulation, because it's more of an everyday occurrence. I think the logbook sometimes is more work than the actual the performance of it. I do think there should be some logbooking moving forward, because then there's credentialing and transparency around that. Because who's to say you've done one, or even somebody could have done 50? It's hard to know. I think credentialing and ultimately transparency around that is key, because if you were to move between inter-hospital, you'd have this portfolio that you can bring along, or a passport. You like your ultrasound images you can save and show another site, another base hospital. So I think moving forward, that will probably be the way of the future. It's probably not mandatory at the moment. We're not enforcing a logbook. It's just more the education in terms of technique, troubleshooting, because it's hard. I understand it's hard on the floor. It's one of those extra things where it's another thing to keep a track on when you've got a busy clinical load with patients, etc., and then you're required after hours to have multiple logbooks on the go. I think there should be logbook for the core things, such as maybe cardiacs or FELS or focused echo and life support, lung, AAA, etc. If it's getting to ultrasound guided cannulation, there should be a minimal standard, but it's hard to police that. I feel it's soon we'll be documenting or logbooking everything. It's a slippery slope.
Yeah, so I think with regards to the logbook, there is this debate that it does not matter how many you have done. What is more important is what is your skill set. Somebody may be competent after doing 5 cannulation under ultrasound, and somebody might need 20. So the number may not be important, but I think if we maintain the logbook, that gives that documentation that we have done something, and when the trainees go from one hospital to another, they have got something in writing that they are competent on that particular field, as you have mentioned.
Well, I think there's a lot more in that scope in that field. I think there's a lot more work to be done, I think, with training, and I think policy, both locally and nationally. I think there's a lot more room. I'd say we'll see space in the future.
Yeah, absolutely. So, Conor, you have mentioned something about the patient perspective. You mentioned that the patient can have got multiple complaints and deep vein thrombosis and infection from the standard technique, and the assumption is that after the ultrasound guided technique, that will probably decrease. From your personal experience, what do you find about the patient's side? What is their perspective when we use ultrasound for getting the IV access or the arterial access?
I think patients love it. I haven't heard any complaints, because I think we're becoming more patient focused anyway, rather than this doctor-led traditional old school method, where traditionally I feel there was an expectation where junior staff were first you'd have to fail so many before succeeding, which is horrible. There's a lot of morbidity for patients that we probably didn't really acknowledge up till this point, to be honest. And for those more challenging or difficult access patients, like we mentioned earlier on, like maybe IV drug use, edematous patients, cardiac, renal, liver, renal transplant patients themselves, patients with some scarring or deliberate self-harm or trauma, burns patients, pediatric, or those particularly more adipose rich, 2-year-old toddlers. And then you have those anticoagulated patients or patients who are on chemotherapy or elderly with very fragile kind of paper mache skin. I think they used to undergo like a lot of like avoidable or inadvertent trauma that we probably caused. And I think the use of ultrasound has ameliorated that, because we said the risk of, thrombosis, phlebitis, and risk of, local cellulitis or then inadvertent with deeper access, either inadvertent DVT or arterial injury was much higher. And then there's a psychological trauma associated with multiple needle attempts or cannulation attempts. And ultimately, we see a lot of patients now with hospital-rated PTSD or retrogenic trauma. And then secondly, there's a second bypasser or clinician kind of probably moral injury associated with that. I think in both nursing and medical staff, it was probably unrecognized till recently in relation to very traumatic cannulations with particularly pediatric patients. So I think the use of ultrasound is huge. It's a game changer. And with that, I think it brings a bit more kind of conscious decision making. Like, I think the ergonomics around it is very important. So I often try and make my first go the best go. I use the use of like in terms of the patient themselves, maybe the use of maybe a local anesthetic on the skin, the 4-point technique like EMLA, depending on the patient's consideration, maybe they might require a sedative, an oral sedative maybe in a child, or maybe procedural sedation or intranasal fentanyl, procedural sedation like nitrous inhalational, or even IM or IV ketamine. Well, obviously you won't have IV, but IM ketamine just for venous access or cannulation. That's becoming more and more commonplace rather than this expectant trauma or distress that we had previously seen in patients. So I think keeping them in mind is always now a part of your decision making and how you'd proceed.
Exactly, yeah. So patient-centered patient management, that's very important. One of the things I practice since I have worked in anesthetics is that I noted that many of the anesthetists, they do not do the cannulation without local anesthetics, even without ultrasound. And so with ultrasound, sometimes, as you have mentioned, that you use ketamine and sedation and some nitrous or EMLA. Sometimes if the patient has got multiple attempts, they failed and there was a bit of bad experience, I put some local anesthetic with a fine needle, like the insulin needle, a little bit of local anesthetic, and then I put the cannula, and they don't feel any pain, and they feel so better. They say, oh, this is the best experience I have ever had. Do you use local anesthetic at all for the ultrasound-guided IV access?
Yeah, I think depending on the patient and your patient choice and the cannula size, or if I was doing maybe an arterial placement, which can be obviously knowingly more painful or irritable, I sometimes instill local anesthetic around the site. And particularly for obviously larger bore stuff like central lines, it's standard. But I think more and more, like, I think it's becoming the norm, the use of ways to mitigate. So for kids, by and large, as soon as they hit the door and it looks like they're going to need a cannula or a venous stab, I'm asking the nursing staff to apply a local anesthetic such as EMLA, ranging just to try and, by the time they need cannulation, hopefully they're cooked or it's topicalized, it's anesthetized like half an hour to an hour later. So I think that is becoming the norm. I don't do it for all my patients in terms of cannulation, but depending on the patient group, particular vulnerable or challenging patients, then it's something I might consider upfront. But it's a great point. I think it does really allay fears. You get better reviews on Uber and doctors. I think it does really massively relieve their anxiety in relation to being in hospital. Like cannulation is one of the most psychologically damaging things we perform. We do it every day and we don't think about that psychological trauma. So I think it's really valuable if we can help them.
It is. Thank you. Now that brings the next topic, the technological advances that you have seen over the last few years. Obviously, there is this AI, there is this handheld devices. Tell us a little bit more about it. You are a very techno-savvy person.
Yeah, I do try and keep up to date. I think the handheld device, I personally have my own handheld device, the Butterfly. Again, no conflict of interest. The downside is if you're in the field and you don't have an alternative, great. I think in hospital where you have maybe a larger device on a standalone on a stand, you're going to get a bigger screen, better resolution, maybe a better hyperfrequency, or we've a hyperfrequency linear probe here, so you're going to get better resolution.
Yeah.
Sometimes the handheld devices, the resolution mightn't be as good, and also ergonomically, having to hold that ultrasound if you have it on your phone or iPad. I see there's these gorilla grips you can put around the proximal aspect of the upper limb, again, to keep the ergonomics, to keep your line of like eyes, needle, and screen. But it does detract if you were to have the screen laterally on the side with the handheld device. So there is that takeaway. I think so. Having a standalone machine usually improves your success. In regards to AI, yeah, sky's the limit. AI, it's controversial. It's like Skynet in the future. I think it will help with identification. Like we're already seeing some AI software in terms of, you know, neurobundle identification and helping with regional technique, and it's definitely already used. It's like automatic with Doppler for arterial identification. The venous system is still kind of playing catch up, but I think that the potential for it is there. It'll show you your best target. It's hard. I think there still is. I still think that we still need like human or clinician gestalt to. I think there's a lot of little troubleshooting. I think you're choosing the best vein, spending time at that is key. Like I think the bugbear, you know, people always tend to, like the majority cannulas are placed in the, say, like the antecubital fossa. It's because usually they're larger veins, they're more linear, you get a longer stretch, but their half-life or length of stay is actually very short due to, you know, patient arm flexion and migration, and then there's always that constant alarm, occlusion, downstream occlusion alarm, which is the bugbear of every nurse's life. I think we just hear this beep.
Yes.
So I think spending time, I know this seems pity, spending time choosing your vein or the venous choice is paramount. It's actually key. If you just wanted a small flow cannula, the patient is stable, maybe the back of the hand, small one. If you just wanted a venous stab, etc. If you want the best actually choice or the longer duration cannula is actually the cephalic vein, where it joins the tributary from the dorsal hand vein, where it's above the wrist joint, and the two tributaries join together. That actually has been shown to have the longest duration because the less risk, it's not over a joint, less risk of migration, and there's no elbow flexion, and less complication rate. So I think technology still can't get that far. I think there still is limitations to technology. It's the simple things like having everything to hand. It might help you with choosing the choice, but at this point the technology isn't there to actually there's no automatic intravenous cannulation device. Well, not that I know.
Not yet.
But you know, who knows in the future? Who knows?
Yes, absolutely. So we have talked about a bit of comparative effectiveness already, as you mentioned that in the old school technique of the cannulation, there are a lot of different complications, and we are hoping, the assumption is that, and from our personal experience, that ultrasound guided cannulation or vascular access are probably more effective. Obviously, a lot of works need to be done in terms of research. And we are hoping to get some better outcome from there. So where is the future, Conor?
No, I think, like I said earlier, the sky's the limit in regards to ultrasound, and just even like in general, but in regards to IV access, ultrasound guided access, I think it's going to become, this use is going to increase. I think people's confidence around it and competency, and hopefully would have more structure and policy to guide and help clinicians perform it. And ultimately, it's for the best. It's for patients. I think our main goal is to make your first attempt your best attempt. And I think there's a lower threshold to use ultrasound earlier, straight away, rather than, you know, your last resort, last ditch attempt. So I think it's not a pride thing. I think it depends on, obviously, as you said, your competency level and competence level. Again, it's not mandatory. I think if you're a senior and you can see an obvious, you know, peripheral topic, like, you know, superficial vein, then you probably don't need ultrasound. I think there's common sense too. But again, for those more challenging patients we mentioned earlier, I think we probably should use it first line. Yeah.
Yeah, I completely agree. Great. So Conor, thanks for sharing all those topics. Do you have any final advice for those users who are new to this technique of ultrasound guided vascular access?
Yeah, I still think it, like, I think it's a procedure you practice. I think you need practice. It's not automatic. It takes a while to get used to it, particularly you're looking at the screen and not down where you're inserting the cannula. So it's like it's kind of a little bit counterintuitive here. And then, but I think getting the cannulation technique just simple, like non-ultrasound guided technique down first, in terms of the troubleshooting and ergonomics, that I can't harp on about that enough. It's kind of my bugbear about the cannulation, the trocar, and the plastic cannula, because I feel that's probably the more common site of error in terms of people pulling the trocar out too quickly and the cannula is outside the vein, or I said a through and through event. And that's irrespective of ultrasound guidance or not. I think so. I think ultrasound definitely has its place, but getting those basic little finer motor skills down is key, and emphasizing that, and then building ultrasound on top of that as an additional skill to confirm and give you a target, but also confirm placement. So I think we're going to see it more and more in the future. I think it probably is the way of the future in terms of for more junior practitioners, or who are less experienced in terms of cannulation. I think it'll be the go-to. It'll be probably the norm rather than the exception.
Excellent. Thank you very much for sharing those golden words. There are a lot of materials out there, of course, with regards to the research papers. This particular paper we mentioned earlier, which is a bit old, but still is very relevant with regards to the recommendations for the ultrasound guided vascular access. There are a lot of video training materials and some good courses as well. I don't have any financial interest, so I would not mention any of them. But if you Google it, you will find them. Thank you, Conor, for taking your time and sharing your expertise. It was a great privilege having you here, and I learned a lot from you. I hope to see you again in another episode. Thank you very much.
No, thank you, Avijit. It's been a pleasure. It's been great talking to you. Thank you for the invite.
Thank you.